this project was really sort of inspired or motivated by a theory called fundamental cause theory, which says, among other things, that inequalities in healthcare have their basis often in social inequalities. And one of the interesting things that has come out of this theory as well is that they sort of propose that the more we know about how to treat a disease, the more likely you are to see disparities. So if the treatments for a disease aren't very good generally, then everyone kind of gets the not so good care. And the difference between people that get the not so good care and no care might not be that big. But as soon as you know better how to treat or prevent a disease, that's when you start to see inequalities and disparities sort of emerge. Because the people in society that have more social standing, that have more wealth, more access, more connections, are better able to harness the innovations that are happening in that space. And myeloma is a wonderful disease population to look into this type of issues, because we've had so much innovation in myeloma over the past 20 years. So this study, I was really looking at trying to determine over time how disparities were changing between Black and white adults with multiple myeloma. And I did this using a SEER Medicare database, which is a somewhat national cancer registry in the United States, linked to public insurance for folks that are over 65. So I looked at Black and white older adults, and the outcomes that I was interested in are sort of these low-level markers of treatment access. So I looked at whether patients were getting treated for myeloma within a year of their diagnosis, and whether they were being seen at National Cancer Institute designated comprehensive cancer center. And this was sort of a proxy for knowing, just having a sense of how many patients were being taken care of by myeloma specialists, and at centers where they could get the most advanced care, like stem cell transplant and CAR T therapy. And so what I found was that for both Black and white older adults, the percentage of patients that were getting treated within 1 year of the diagnosis was increasing across time. But at each time period, there was a significant gap. The gap in 2007 to 2010 for between Black and white patients was about 6, and then it increased to about 9 in the most recent time period, which was 2015 to 2017. Although that change was non-significant, what we can see is that there's a significant gap, and that the gap itself wasn't getting smaller. So disparities exist, and for a treatment access within 12 months, we know that the gap itself is at least not getting smaller. In terms of access to NCI comprehensive cancer centers, that gap did get significantly bigger. In 2007 to 2010, the Black-white gap was about 5. And then in our most recent time period, 2015 to 2017, the gap increased to about 12. And that did significantly increase. And so at least for these outcomes, we can see that there are significant gaps between the care that Black and white patients get, and that it's not decreasing over time, and that it may in fact be getting bigger. This work I think is incredibly important in a disease like myeloma, where the care is incredibly complicated, and it's getting more complicated, more expensive, and harder to access all the time. So at a meeting like this, it's wonderful to hear about all the new drug discovery that's happening, but I think it's also important to include in the conversation an understanding that even if we have a wonderful drug, if patients aren't able to get it, then we still have work to do. And I think this work is somewhat motivated by the notion that any myeloma patient that needs care should be able to get the care that they need. And it's not a reality in the world that we live in. We know that not everyone has access to the care that is hypothetically available, but in the real world is not always as available to everyone. Describing these disparities is a great first step, but there's a lot of work that we need to do to understand why these disparities exist, and what's potentially driving them. So I have some work going on where I'm trying to get a better understanding of the factors that are driving these gaps and why they might be changing for the worse. And also the next step after that is obviously once we have a better understanding of what might be driving these disparities, is to work to develop interventions that can potentially improve the situation. And so I'm hoping in the next 5 years to do some work around patient navigation to help patients overcome barriers to treatment access. One thing that's not in this work, but it might be worth mentioning, is that when I did an analysis of what types of treatment patients get, once they get treatment, the disparities don't completely go away, but they do shrink. So for example, if a patient starts treatment, the percentage of Black patients and white patients that get novel therapy is about 98, 99%, and there's no disparity. I also looked at, if a patient starts treatment, do they get novel triplet therapy, which it's currently the standard of care is changing all the time, but that's been the standard of care for a while now, and the disparities in that case are much smaller. And we see that in that case, the disparities are actually getting smaller over time. So if we can get patients to treatment, that seems to be a big roadblock. And so my work with patient navigation is going to be trying to identify patients that are at risk of not getting their myeloma treatment started, figuring out what barriers they have, and getting them to treatment.